Okay, welcome. So, Sheila, welcome. Thank you very much. All right, so let's start our discussion. The discussion is there was a question from a cool bean saying, does statin use increase the risk of dementia or Alzheimer's? So, that is the basic topic today. And the short answer from the studies that I've seen and I'll present to you is that actually statin use reduces the risk of dementia and Alzheimer's. And those who are diabetic and are using statin, it reduces even more the risk of dementia and Alzheimer's. And those who already have Alzheimer's or dementia, statin use reduces further aggravation or exacerbation of these or progression of these diseases. The question that we would answer today is that there is a side effect. So, one of the cool beans pointed out that one of the side effects of statins is cognitive impairment. So, how come there are studies that are going to say there is improvement, reduced risk of cognitive decline versus some mechanism where the impairment could occur? So, I'll discuss these two. Then we'll look at the mechanism for how does this happen? What is the role? How do why do statins have a side effect of cognitive impairment? What is the mechanism for that? And then how do statins actually improve cognitive decline or reduce the risk of cognitive decline? We'll look at that mechanism. And then we'll look at studies too. So let's start. I think this is a very, very interesting lecture today. So in this lecture, today we would also discuss about nuclear factor kappa B, toll-like receptors, and MyD88 inflammatory pathways. So I have already discussed them. So if you see here on drbeen.com, in the inflammation, you would see that these inflammatory pathways, I know my D88 I had already discussed within the other pathways, but here, as you can see, nuclear factor kappa B is here, and then the toll-like receptor pathway is here as well. I just do not think they have uploaded it yet. So these pathways are present here. So if you wanted to have a deeper understanding of those pathways, you can see that. Now, before I go to the studies, I want to show you the mechanism. So this mechanism that I'm going to present now is why do statin act as an anti-inflammatory molecule, and then can that help with reducing the risk of dementia or Alzheimer's and or Alzheimer's? So let's see. Statin pathway starts from acetyl-CoA and acetoacetyl-CoA. And we have done this discussion before that acetyl-CoA from the glucose or from proteins or from lipids, acetyl-CoA can be formed from many sources. Then acetyl-CoA can be pumped into Cori cycle or Krebs cycle where it helps make ATP. However, some acetyl-CoA is used in HMG-CoA pathway. So right now what you're seeing is one pathway for acetyl-CoA to go towards helping make cholesterol. So that is the HMG-CoA pathway. We discussed this last time as well. I just have it a little more, you can say, written out today just so that we can record it too. So here is acetyl-CoA and acetoacetyl-CoA. These two combine to make HMG-CoA. It is the HMG-CoA which is converted to mevalonate by the enzyme that is called HMG-CoA reductase. This enzyme reduces the HMG-CoA to make mevalonate. Is this interesting for us? Probably not. The only thing that you would see is that you'll see a study where they had the vascular cells co-incubated with statins. So if the vascular cells are incubated with the statins, you would expect that this pathway would become blocked and they would have less inflammation, the vessels. On the other hand, if you put mevalonate in that petri dish as well, then you are really defeating the purpose of statins, because the statins' purpose is to block the formation of mevalonate. So they added mevalonate separately and they saw that statins action went away. So you would observe in that study that they proved that the pathway for statin activity is this pathway, HMG-CoA pathway. So what happens is HMG-CoA reductase produces mevalonate. I'm going through the normal pathway without statins acting. Mevalonate is then further converted, and so it is converted into isopentenyl pyrophosphate. Isopentenyl pyrophosphate. The isopentenyl pyrophosphate is then further converted into farnesyl pyrophosphate and geranyl pyrophosphate. Now, this farnesyl pyrophosphate can also be converted to geranyl pyrophosphate, or GGPP we call it. So this one, farnesyl pyrophosphate, is written usually as FPP, and the other one, geranyl pyrophosphate, as GGPP. The farnesyl pyrophosphate then further goes through 3-4 steps of more molecules, finally to make cholesterol. We know the statin pathway only from this point of view, that when we give statins, they will block the HMG-CoA reductase enzyme. That would reduce the production of mevalonate, and this whole pathway would become disrupted, and we generally know that cholesterol production will reduce. Last week when we were discussing it, we also discussed that CoQ10 production will also reduce. And if you can see here, farnesyl pyrophosphate gives rise to, through multiple steps, cholesterol, and then farnesyl pyrophosphate, this molecule actually combines with tyrosine or phenylalanine and makes CoQ10. So the summary that the HMG-CoA pathway helps make cholesterol and CoQ10. Now, usually just this much is known. CoQ10 is very important as well to know. That means when the statins are reducing the production of CoQ10 as well, CoQ10 is a very potent antioxidant inside the mitochondria. And so when there is a reduction in CoQ10, that can lead to increased reactive oxygen species and cellular damage. So CoQ10 supplementation is good with statins because they would make up for the reduced amount of CoQ10 produced. Now, on the GGPP side, this enzyme or this molecule helps with something that is called protein prenylation. And I was confessing today that through my undergraduate studies and from then till now teaching medicine, I had actually not heard of the protein prenylation. So I thought a lot about it because I was kind of kicking myself that why did I not know this? And I can understand that undergrad books do not have it because it is slightly advanced topic and they should care less about prenylation. And then in the future, I probably looked less in the metabolic pathways with less care or less depth. So protein prenylation, what is that mechanism? What is it? So before that, let's see for a second, if we have a cell and we have cell membrane is not just a barrier for the cell, that there are some things that are inside the cell and they should not get out, and there are some things that are outside the cell and they should not come in. Cell membrane is an active surface. It is like a harbor. It's a docking place where lots of channels are working, lots of proteins are working. On the inner side of the cell membrane, there are so many proteins that are attached, dangling on the inner side. So if you are standing inside the cell and you look up, you'll see this dome-shaped cell membrane everywhere making up the sky. And from that sky, you will see various proteins dangling. These proteins that are dangling there, they need some way of getting inserted in the cell membrane and getting stuck to the cell membrane. Just like a ceiling fan, which I would really have loved to have today because I'm sweating. The ceiling fan needs some sort of a hook to bind it to the ceiling. Otherwise, it would fall. So when you get the ceiling fan, it doesn't have the assembly to connect to the ceiling, and then you put that assembly on and then you hook it on the ceiling, and that's it. It is dangling there now. That is the same thing. When we take a protein and attach a hook with it, that would allow this protein to go and get stuck in the cell membrane inner side. This mechanism is called prenylation. And the purpose of prenylation is to make a protein insertable or attachable to the inside of the cell membrane. So then the second question will be, why do we need prenylation? Why do we need cell membranes attached to the inner side of the cell membrane? Why do we need proteins to do that? Because cell membrane has a lot of receptors on its surface which are responding to the outside messages or messages that are coming to the cell membrane through the, for example, insulin is coming in, growth hormones are coming in, thyroid hormones are coming in. Some hormones go inside the cell, some work on the outside. So when a hormone or a message works on the outside of a cell, there needs to be someone on the inside to respond. For that, there are little complexes that are attached on the inner side of the cell membrane to do that response. So now if I go back here, the GGPP, its role is to bind with various proteins. It itself binds with the proteins. Oh, and if you can see here, farnesyl or geranyl, they both can actually get inserted or attached to other proteins, the proteins that were made in the normal process of, messenger RNA from the nucleus, and then that goes to the ribosome of the cell, and the ribosome reads that messenger RNA and makes a protein. Then that protein is folded and all that. So that is all happening, and the protein is now in the cytoplasm or in the Golgi apparatus, depends where this should be. And then we need to prepare it to be attached to the cell membrane. So what we do is, on the cysteine residue, cysteine is one of the amino acids. Proteins have tons of amino acids and repetitions of them. Cysteine is one such amino acid. So for the healthcare professionals, on the carboxy end of the protein, so proteins have a nitrogenous or amino end and a carboxy end. On the carboxy end, the closest cysteine to the carboxy end have farnesyl attached to it or geranyl attached to it. So these guys, where did they come from? From this pathway, HMG-CoA reductase pathway or HMG-CoA pathway, right? So they come in and they prepare the proteins to get to the cell membrane. Okay, good. Then what? If these proteins can go to cell membrane now, yay for the proteins, but then what? Here is the important thing. I'll give you some examples. Nuclear factor kappa B is a pathway, inflammatory pathway, for which the complexes, some parts of the nuclear factor kappa B machinery are actually attached to the cell membrane inside. And they're listening to the receptors outside, and they're trying to figure out, do I need to produce inflammation within the cell? And there could be cytokines, for example, tumor necrosis factor alpha or other cytokines that could come and signal to the cell membrane of a cell that, hey man, you need to produce inflammation, and then nuclear factor kappa B can become activated. So parts of the nuclear factor kappa B machinery are attached to the cell membrane. Similarly, toll-like receptor. What are toll-like receptor? And I'm only giving examples for those that I'm going to use today. So toll-like receptors. Toll-like receptors are receptors on the outer surface of the cell membrane of the cell, and these are called pattern recognition receptors. These receptors' job is to recognize viruses and bacteria and the parasites and broken cells, etc., debris and things like that. And then based on that sense that they get from the environment, they can activate various inflammatory responses. So toll-like receptor pathway is very important. Toll-like receptor pathway itself can, secondarily activate nuclear factor kappa B pathway. I've done this discussion in the pathways. Then MyD88, that is another inflammatory pathway, and that also has some complexes attached to the cell membrane. So you can think of this as an example that imagine in your home, there is some people talking outside, and you are curious at what are they talking about. So you go to your door and you put your ear on the door and you're trying to hear what is happening outside. So your ear helps you attach to the door, not hang with it, but just attach to the door. So that ear is prenylate protein. And then you are able to hear outside. And now when you hear something, you might react inside. This is what these membrane associated proteins are doing. Some are acting as channels, some are acting as second messenger systems or responders, etc. So now nuclear factor kappa B, toll-like receptor, MyD88 are inflammatory pathway. There is an honorary mention for one more pathway, and that is the arachidonic acid pathway. You know that the arachidonic acid pathway has the arachidonic acid in the cell membrane. And whenever we need to produce inflammation and pain, we activate an enzyme called phospholipase A2, or there are various kinds of it. That phospholipase enzyme goes to the cell membrane, plucks the arachidonic acid or even omega 3s, whichever omega it can see, it would pluck that. And that would start, if it is omega 6, then that would start arachidonic acid pathway activity, eventually making various kind of inflammatory molecules. Why I mentioned that has nothing to do with statins. But as you see, statins modulating nuclear factor kappa B and um, toll-like receptor pathway and MyD88 inflammatory pathways, then you might say that, hey, if we need to do that with statins, why can't we just have ibuprofen, for an example, or NSAIDs, non-steroidal anti-inflammatory drugs, and they can also reduce inflammation. But their pathway is different. They are arachidonic acid pathway manipulators. Today, you would see statin as a manipulator of nuclear factor kappa B, toll-like receptor, and MyD88. And it is interesting that these pathways have a very different way of doing inflammation. And normal anti-inflammatories cannot modulate these pathways. Okay, so now we know that farnesyl and GGPP can do prenylation of the proteins, and those proteins can get inserted in the cell membrane. One more example that will be used for today's discussion. There is an enzyme in the cells called NADPH oxidase. Here I've made that. Imagine that this is a cell. And so inside of this it looks like a little crooked cell. So here's a cell. NADPH oxidase is an enzyme complex. When we say complex, what that means is it is made, this is a machine, but made up of many small components. Just like your car is made up of many small components, there is engine and there are motors and there are cars and tires and whatever, right? Similarly, NADPH oxidase is an enzyme complex, but it is made up of many smaller proteins. The function of NADPH oxidase, or NOx, is to make reactive oxygen species. Its job is to make reactive oxygen species. Have you seen sometimes you buy those bubble making machines nowadays, but in the past we used to get little soap and a wire ring, and we'll dip the wiring and we'll blow into it and that would make bubbles. That is a function of NADPH oxidase, to make reactive oxygen species. So you might say, why reactive oxygen species? Why do we need to have them? They are so dangerous. But reactive oxygen species are actually important for signaling and many other mechanisms, especially in the immune system cells. And I had made this diagram in the past um, for the book, immunology book, which now got converted into inflammation book. So if you see here, this is a neutrophil. And the neutrophil has many, many structures that are neutrophil related. But what is here interesting is this little um, burner inside the neutrophil attached to the cell membrane. This is the NADPH oxidase system with the vesicles. So what happens is this fire that is burning here, it needs reactive oxygen species, and then those species become converted to even more species. But eventually this uh, this area, this vesicle, when you put a virus in it or a bacteria in it or another pathogen or piece of pathogen, it would burn it out. It makes bleach in here and destroys them. So this is where NADPH oxidase works to make the very first reactive oxygen species. From that, the rest of the pathway makes eventually bleach, and then we use that bleach to kill the pathogens. So reactive oxygen species production is actually useful for many of the um, antimicrobial activities. So Sheila says, so can statins lower immunity? I don't think that statins are that potent to lower immunity, that potent for this pathway. So I have never heard of statins uh, impacting immune system so much that we cannot handle the um, immunity or the microbial immunity, antimicrobial immunity. So here, NADPH oxidase. NADPH oxidase has a protein called RAC, as part of its complex. That protein RAC is prenylated by GGPP. So what happens is whenever we need to make reactive oxygen species, imagine that there is a virus attacking the cells, and this is a neutrophil and it is going there and going to, you know, clean up and fight with the viruses. And so it, or a bacteria is present or a fungus is present. And so the cell needs to start producing reactive oxygen species. So what it would do is all those components of NADPH oxidase that are floating around in the cytoplasm, they will be given a trigger, they will be given a message to go assemble on the cell membrane and make NADPH oxidase. And when it will be formed, it will make reactive oxygen species. One of those proteins is RAC1 or RAC2. And RAC1 or 2, to become attached here with the NADPH oxidase, need to be prenylated by the HMG-CoA pathway, by the farnesyl pyrophosphate and guanylyl pyrophosphate. So if we give statins, what will happen? Now let's look at statins. When we give statin in this system, how many things will happen? This is why statins are called pleiotropic drug. That is, their job is not just lipid lowering. They have more functions than that, and you would see those functions now. This is why also they have tried to compare the function of statin to other lipid lowering drugs, and they found out that statins actually function even more than just lowering lipids. And we have, I did this study with you somewhere a few months ago, where the title, I believe it's on YouTube as well, the title was Inflammation Beats Cholesterol. And that was a study where there were people who had a cardiovascular event, so a heart attack or angina or stroke. They were all on statins. And then one of the group was also given anti-inflammatories, in addition to statin being anti-inflammatory, as you'll see today. And they were all taking that. So that was the cohorts were equal in terms of statin usage. Then they added anti-inflammatory on top for one group, and that group had significantly lower, statistically significantly lower risk of next cardiovascular event. So just the presence of lipid itself isn't that big of a problem. The problem becomes apparent when inflammatory status is also present, which causes these lipids to become beta oxidized, to become oxidized, and then irritate the macrophages and in the blood vessel walls, and they pick them up and become foam cells and cause inflammation. So inflammation control is really important. So Nipa says low dose colchicine. So colchicine is a good drug for anti-inflammation, but it scares me. This drug has side effects that are a bit more pronounced. So now let's see if the statins are used, then what happens? When we are administering statins, HMG-CoA reductase enzyme is blocked or its activity is reduced. When that happens, less amount of mevalonate is produced. When that happens, less amount of all of these substrates will be produced. That means less amount of cholesterol is produced. That is what we want. And a byproduct is less amount of CoQ10 is produced. That is not what we want. So we should have a supplementation. Then, as the less amount of farnesyl and geranyl are produced, that means less protein prenylation happens. That means, especially which proteins? Rho, RAS, and RAC. These three. Now, Rho, RAS, and RAC proteins, we'll look at their functions in a second, but they are generally um, used for cells to have nuclear factor kappa B pathway activated. They are used for toll-like receptor system, that inflammatory pathway activated. They're used for MyD88 pathway activated. They are used for cellular mobility. So when the immune cells are moving from point A to point B and they're going to go there and cause inflammation, their motility of the cell is actually dependent on Rho, for example. Rho, when activated, helps activate actin system, which is another protein system that helps the cell move. So all of those, and similarly RAC here, as I just said, is important for NADPH oxidase, which makes reactive oxygen species. So when we have given statins, then the Rho, RAS, and RAC activity is reduced. That means activity of nuclear factor kappa B is reduced. And mind you, as I said before, this cannot be done by arachidonic acid pathway manipulation. That is the NSAIDs. So NSAIDs can directly affect arachidonic acid pathway. They can indirectly affect nuclear factor kappa B, but not directly. And nuclear factor kappa B is a potent inflammatory system. So here statins are working on it. Similarly, toll-like receptor and MyD88 and reactive oxygen species production. So when you see this side, you would see that statins reduce inflammation and they reduce immune system activity. Not so reduce that people start getting infections. They are not like steroids. Only steroids have such potent effect. I have never seen, even other anti-inflammatories do not block the system so much that we can't then handle other pathogens. And secondly, usually these anti-inflammatories are given to someone who has extra inflammatory state. So you are shaving off that extra state. So imagine if this was the normal level of inflammation or these pathways activity, and here somebody has extra activity, and that is causing damage, atherosclerosis and other tissue damages, cardiac hyperplasia, cardiac fibrosis, neurocognitive declines. So this is where these pathways are overactive and are causing harm. So when you give anti-inflammatories, you are trying to shave off this part, not zero out the immunity or the inflammatory pathways. And because of that, if you come back here or even a little lower, that would not take away a person's ability to handle their needs through inflammatory pathways. So what happens specifically in terms of the inflammatory cytokines? As the nuclear factor kappa B pathway is reduced, interleukin 6 production and tumor necrosis factor alpha production is reduced. And that is a really important thing, because tumor necrosis factor alpha can go to brain and activate the glial cells of the brain. And when these cells are activated, they would start causing neuronal damage. They would start causing synaptic trimming, and they would, or snipping, synaptic snipping and trimming, and even cause neuronal death. And similarly, when the interleukin 6 and tumor necrosis factor alpha are produced, they will go to liver, and liver will then make C-reactive protein. So when statins are given, people have reduced amounts of IL-6, thiamine necrosis alpha, and CRP production. So, so there is a discussion going on in the comments, which is, so cancer and low dose colchicine. Yes, as long as you can. So there are going to be some people who respond negatively to colchicine. So one just has to be careful for that. Um, I believe American Heart is talking about colchicine as prevention and cure. So colchicine is interesting, but it has its side effects, which are kind of the basic reason for the colchicine side effects is this: colchicine um, reduces a cell's ability to move, and that is why it kind of reduces the activity of immune system cells. The cells are present, but they just cannot go to where they need to produce inflammation, and maybe they cannot go to where they are unnecessarily producing inflammation. So that is how colchicine actually helps. It blocks the microtubular network formations, but then it can block it so much. We use it for cancers, right? It can block it so much as well that normal activity can be impaired. Colchicine can, number one, cause severe side effects within the body because the cells cannot make their microtubules to do normal functions. And secondly, it can impair the immune system activity enough and sufficiently to cause infections, just like steroids do it. But it's a good drug. So interleukin 6 is reduced, tumor necrosis factor alpha is reduced, and CRP is reduced. So with this mechanistic approach in our um, belt, under our belt, now let's look at some studies that talk about the um, dementia and statin. Faraz says, can you relate this lecture to rhabdomyolysis? We can do that. So as I discussed the muscles a few weeks ago, we'll do that. Maybe next week we discuss that. Mike says, what is the gastric source of impact from colchicine? So wherever there are cells that are replicating and that are functioning and their microtubular structures are reduced, they would have an impact. GIT generally are producing new cells, and new cells would have new microtubular structures as well. So they can be impacted. And again, it would depend upon the dose, it would depend upon this system state, how many new cells are being formed, how urgent is the need to reduce them. For example, in a case of cancer, too many cells are being formed and we want to reduce them. So one has to look at patient's state. Okay, before we go to the studies, I want to share one more thing. So Bill Beers, who was here in the earlier session, he said one of the side effects of the statins is the cognitive impairment. How does that happen? So I wanted to record that here as well. That as you would see that the statins reduce the risk of cognitive decline, they can actually cause cognitive impairment as well. And here is that mechanism. So what happens is, as we discussed last week, when statins are given and cholesterol is reduced, cholesterol is a very important part of the cell membranes, and it imparts, it kind of punctures the cell membranes and provides fluidity to the cell membrane. That fluidity is very important for various transporters that are running around, various proteins that are running around. We call them, some of them, that they are stuck in what we say lipid rafts. Rafts are like little boats in which these proteins are stuck, and then they are just floating around on the cell surface and looking for their signals and binding with them, etc. Similarly, we discussed that there are some channels on the cell membrane that are primarily inverted, that are on the inner side. Their active face is on the inner side. And when they need to become active, they would flip, and their active face will go on the outer side. And that is how they'll start functioning. Similarly, for our cells, let's say muscle cell. Our muscle cells and other cells too, they have glucose transporters in a vesicle, right? So these glucose transporters are present and they are sequestered, as we use the word, sequestered in a vesicle. They are packed and stored in a vesicle. When the insulin comes in and knocks on the insulin receptor and tells the cell that, hey, there is glucose outside, you can insert your channels and pick up the glucose. So the cell then responds by moving these vesicles towards the cell membrane, fuses them with the cell membrane, and these transporters are now inserted in the cell membrane. So for this function to happen, the cell membrane has to be fluid and flexible. If we reduce cholesterol, the cell membrane is not as fluid, it is not as flexible, it is brittle, hard, rigid, which causes the cell membrane to have many functional abnormalities. Examples, for example, cells can have a problem picking up glucose. That will be called insulin resistance. So how come less cholesterol lead to the insulin resistance? When there is less cholesterol, there is rigid membrane, and the even when the insulin is present and it is knocking at the door and the cell wants to bring the glucose transporters to the cell membrane and insert them in there, it cannot, because the cell membrane is rigid and stiff. And it is not easy to insert glucose transporters in there. So all of a sudden, the cell wants to get glucose, has all the equipment to get glucose, but the membrane is so hard that it cannot insert enough number of glucose transporters to pick up the glucose. This cell is now insulin resistant. When the cell is insulin resistant, where would the glucose live? Outside of the cell. Why? Because it is not picked up. Similarly, we discussed it last time that beta cells, whose job is to make insulin and release insulin as a response to glucose levels, when the beta cell has less cholesterol in its membranes, it is also rigid. And now we want to release insulin. So imagine you have eaten something that has glucose, and the glucose is getting into the beta cell, and the beta cell is now making reactive oxygen ATP and then reactive oxygen species. That is a signal for the beta cell to say, hey, release insulin. And now the insulin is present, sequestered in a vesicle. This vesicle need to open up on the surface to release insulin. And this opening up of the vesicle on the surface needs a pliable, soft membrane that can be opened. So if the membrane is rigid because there is less cholesterol in the membrane, then the insulin release will have a problem. So now we have two problems. Insulin availability is less. Although the insulin is present within the cell, it wants to go out, but it cannot. So in the body, there is less insulin. And then on the receiver end, even when the glucose transporters are in the cell, they want to go out and get inserted and pick up glucose, they cannot. The result is a state of insulin resistance, reduced insulin, and diabetic-like state, which will mean glucose levels will increase in the blood and interstitium. Interstitium is the spaces between the cells. And we know that when glucose levels are increased, that unnecessarily, pathologically, that would cause non-enzymatic glycation. This glucose would start sticking onto the cell surfaces unnecessarily, just like dust would settle on surfaces. This is called non-enzymatic glycation. So the cell surfaces would have even more problem now. Mud has gotten stuck on them. If the cell has celias, those, for example, respiratory system has ciliated cells that whose job is to move the respiratory fluids, those cilias would not work correctly. Endothelium of the blood vessels will not work correctly because there is glucose stuck on their surfaces. Neurons will not work correctly because glucose is present in extra amounts and not getting into them. So the cognitive impairment is because of the extra glucose caused by statins and reduced cellular flexibility, the cellular membrane flexibility, which will reduce their function anyways. These two things together will or can cause cognitive impairment in some individuals. So now you are seeing two balancing acts. On one end, in some people, cognitive impairment can occur. And these are the two mechanisms. What are the two mechanisms? Neuronal cell membrane stiffness because of lack of or reduced cholesterol levels. And number two, increased glucose levels, which are also a result of reduced cholesterol levels. And on the other side, how can we have the cognitive impairment or dementia risk reduced by statins? Because of all those pathways that we just discussed, which eventually lead to reduced inflammation. So now let's look at the studies. I'm going to quickly see the comments going on. So Faraz says, what are the practical implications of the facts revealed in your lecture? For example, food choices. Look, if we can help our inflammation, this is why I'm writing the book on inflammation. This is why I did this lecture set on inflammation. And here is a toll-like receptor and NLRP pathway. Inflammation is the primary thing to control. So foods that can cause inflammation, we should reduce them. Then foods or herbs or supplements that can help against inflammation, and not only just the arachidonic acid pathway, but nuclear factor kappa B pathway, toll-like receptor pathway, NLRP pathway, MyD88 pathway, MAP kinase pathway, ATK pathway, AKT pathway, JAK-STAT pathway. You can see them over here. And for us, what I had done was, remember when I was doing the inflammatory pathways, I believe this is a gem, these pathways. I had actually listed out various herbs and lifestyle and allopathic medicines that can help modulate those pathways. So if we all at least know these pathways and what modulates them, then that answers your question for us. So CoQ10 should be taken, absolutely. So I'm reading Faraz's comments saying that you probably have discussed this before as well. So yes, CoQ10 should be taken with statin if statins are needed. And then we should look at the C-reactive protein levels of a person to see how are those levels and is the inflammation under control or not. And Mike Ma says, what about lipophilic versus hydrophilic statins? And I am going to discuss that because, so let me give you the short answer. Majority of the studies showed no difference in their ability to reduce the risk of dementia for being hydrophilic or lipophilic. There was a thought that lipophilic statins are better because they can cross the blood-brain barrier and get into the brain and affect brain more. However, you would see in the studies that I'm going to share, no difference. So let's start with the studies. All the good questions that have teed me up to have this discussion. So this is the first one. This is European Society of Cardiology, 18 January 2022. Do statins increase the risk of dementia and Alzheimer's disease? So there's a doctor who has written this, and this is a study that was published in 2021 December in Journal of Preventive Cardiology Europe. She has some excerpts here, which I'm going to read some parts of them. So look at this. In total, a pooled analysis, so that was a meta study, of 36 studies found that statins were associated with a decreased risk of dementia. An odds ratio is 0.8. That means 20% reduction in the risk of dementia with statin use. For Alzheimer's disease, the association with statins based on 21 studies was also reduced, and the odds ratio is 0.68, so 32%. And the range is even better. There was no sex difference in the risk reduction. The results were similar for lipophilic and hydrophilic statins, Mike. and stronger for high potency statins compared to low potency statins. The authors conclude. So the question then becomes, do you look at a person who may have a risk of dementia and say you should take statins? Number one. And the second question that becomes, should we give statins to people or not? Is there a risk for dementia or not? So here is the answer to those questions. The authors conclude that the results confirm the absence of a neurocognitive risk. So why didn't they just come out and say there is a benefit? The reason for that is there is a lot of this debate going on that do statins create or increase the risk of dementia? So because of that, you'll see many studies coming out saying no, they don't, and yes, they are neuroprotective. So instead of just simply saying they are neuroprotective. So this is why you see this structure of the narrative. So if you see here, the authors conclude that the results confirm the absence of a neurocognitive risk related to treatment with statins. In addition, the authors conclude that this study supports the recommendation of using statins in both primary and secondary prevention of cardiovascular diseases, even in older subjects, as there were many older subjects enrolled in the studies that were included in the analyses. Cognitive consideration should not play a role in decision making for most patients when statins are indicated. So this is the side effect that they can cause cognitive impairment. So my answer would be actually very simple. Instead of this statement to read it to the patient and say, well, here is a statement that says it should not be a problem. Very simply, what you have to see is, why did the cognitive impairment occur? Glucose levels increased and cholesterol level too reduced, right? So check the patient's glucose level, keep their diabetes under control. And then they don't have that factor. And then second part is the cholesterol levels. So that is going to be case by case depending upon what is the severity of the risk for cardiovascular event and do we need to very aggressively reduce cholesterol or not. Finally, although the authors suggest that there might be a favorable role for statins when it comes to prevention of dementia, they discuss the risk of bias in the observational studies. So that is a limitation that this is a meta-analysis of the observational studies, so there is a risk of bias there. And that usually that bias is towards healthy patient bias. And they do not state that this should be recommendation. So they said because of the meta-analysis, we found these things, but we are not coming out to say give statins for reducing dementia. So this is one study, interesting one, or an article about the study. So here is another study, Alzheimer's Association, 2025 January 16. I think this is the most recent one that you would see. Dementia affects 55 million, projected to increase further. Statins are widely used. So here they are saying that this is also a meta-analysis. So they looked up PubMed, MBAS, and Cochrane, and then they did a meta-analysis. So what did they find? We assess the risk of dementia, Alzheimer's disease, and vascular dementia with subgroup analyses by gender, statin type, lipophilic, hydrophilic, and high potency, low potency, and then diabetes status. So what did they find? 55 observational studies, once again observational, including over 7 million patients, were analyzed. Statin use significantly reduced the risk of dementia compared to non-users. Hazard ratio 0.86, so 14% reduction. It was also associated with reduced risk of Alzheimer's disease, hazard ratio 0.82, so 18% reduction, and vascular dementia 0.89, 11% reduction. Subgroup analyses revealed significant dementia risk reduction among patients with type 2 diabetes mellitus. Why? Because type 2 diabetes mellitus causes inflammation, and it is caused by inflammation, right? So when you are giving statins and they are working on nuclear factor kappa B pathway, they are working on the toll-like receptor pathway, then they're working on the MID88 pathway. Uh, One thing I did not discuss there, which you would see in a next study, is that statin, by acting on RAS, RO, and RAC, they not only reduce inflammation, they also reduce the immune system cell motility. Just like we were talking about colchicine, but colchicine is much strong, that is made for that. They have a side effect of reducing their motility, which causes a reduction in inflammation because a huge army of cells do not reach, let's say, brain and try to attack it, or other tissues. They don't go to brain. Brain's own glial cells become activated. So those who have diabetes, there was a significant dementia risk reduction. So that was hazard ratio was 0.87, so 13% reduction. Those with exposure to statin for more than 3 years, look at their hazard ratio, 0.37. 63% reduced risk of dementia, 63%. And population from Asia, where the greatest protective effect was observed. Where the greatest protective effect was observed. And what was that? 84, 0.84, so 16%, right? Additionally, rosuvastatin demonstrated the most pronounced protective effect for all-cause dementia among specific statins. So when they looked at individual statins, rosuvastatin was the best. And what is the effect? Hazard ratio 0.72. So about 28% reduction. Our findings underscore the neuroprotective potential of statins in dementia prevention. So Nipa is talking about berberine. I did remember Nipa did a lecture about the berberine, or maybe more than one. It's present on YouTube too. Berberine has a very good effect as well on diabetes control and helping reduce the cholesterol levels too. So yes, the only difference is statins are prescription, berberine is over the counter, but has, remember I did that study where I discussed the plaque size reduction with berberine? So berberine within 4 months of usage had reduced the arterial plaque in the coronary arteries. So yes, it is very, very useful. Okay, so this is another study. I think they have a forest plot as well. I have so many studies that here. I was showing this in the morning. You would see that some studies here actually are not significant. For example, this top study here, if you see, it crosses the unity 0.53, 95% confidence interval to 1.23, so not significant results. But when you take their data and then synthesize a bigger set of 7 million people, and then you reanalyze them as one, set of groups, then the data becomes um, significant. And it is possible that one study doesn't have enough power, doesn't have enough population, doesn't have enough metrics, and so that is why it was not significant, but it can contribute that data for the bigger analysis. Similarly, if you see here, this study 0.8 to 1.6 also not significant. So there are some significant and some not significant. And you might see that there are some studies that are leaning towards harm. So for example, this study is leaning towards harm. But when you did the overall 7 million people's analysis of taking these studies, then the results were as I read them before. It's interesting um, meta-analysis. Then here is another. Mike says, I've been taking berberine ever since diagnosis of type 2 for 7 years, and my A1C remains at 6. Only other drugs is jaundice, Jardiance for the last 2 years. Very interesting. Thank you for sharing. Preventive Cardiology, European Journal, Oxford Academic. And the study date is March 2022. This is Statin Use and Risk of Dementia or Alzheimer's Disease, a systematic review and meta-analysis of observational studies. Aim, As the potential impact of statins on cognitive decline and dementia is still debated, we conducted a meta-analysis of observational studies to examine the effect of statin use on the risk of Alzheimer's disease and dementia. What did they do? They also did a research on the existing studies in PubMed, Cochrane, and Embase. And what were they looking for? They included studies that had cohort or case control studies, statin user compared to non-users, and Alzheimer disease and dementia risk outcome studies. What did they find? They measured the effect were reported as measure of effect were reported as odds ratio. So what did they find? In the pooled analyses, statin were associated with a decreased risk of dementia, 36 studies, 0.8 odds ratio, so 20%, and of Alzheimer's disease, 21 studies, 0.68, 32%. In the stratified analysis by sex, no difference was observed in the risk reduction of dementia between men, 0.86, or women, 0.86. Similar risks were observed. So here the risk doesn't mean that there is a risk of dementia, but risk reduction. But because the risk is the term and they're giving odds ratio and the odds ratio is lesser than 1, that means it is risk reduced. Similar risks were observed for lipophilic and hydrophilic statins for both dementia and Alzheimer's disease, while high potency statins showed a 20% reduction of dementia risk compared with a 16% risk reduction associated with low potency statins, suggesting a greater efficacy of the former, although a borderline statistical significance for the heterogeneity. So, meaning it was not too significant, it was already borderline, so kind of equal. The results confirm the absence of neurocognitive risk. See, once again, negative term here. Because everybody asks about, hey, is there a possibility of statins causing cognitive decline? Because one of the side effects is cognitive impairment. And so this is a very valid curiosity to say, am I at risk? So then studies respond to that curiosity and question and concern. These results confirm the absence of neurocognitive risk associated with statin treatment and suggest a potential favorable role of statins. So this is another. Then here is statins and cognitive decline in patients with Alzheimer's and mixed dementia. So now these patients already have Alzheimer's or dementia. What do statins do to them? And this is also pretty recent, 20 December 2023. Disturbances in brain cholesterol homeostasis may be involved in the pathogenesis of Alzheimer's disease. Lipid-lowering medications could interfere with neurodegenerative processes in Alzheimer's disease through cholesterol metabolism or other mechanisms. That's their background. What they wanted to understand was to explore the association between the use of lipid-lowering medications and cognitive decline over time in a cohort of patients with Alzheimer's disease or mixed dementia, with indication for the lipid lowering, meaning they had cardiovascular risk as well. So methods, they did a longitudinal cohort study. This was a longitudinal cohort study. This is not a meta-analysis, using the Swedish Registry for Cognitive Dementia Disorders. And they used mini mental status state examination as the exam to understand. What were their results? Our cohort consisted of 15,586 patients with mean age of 79.5 years at diagnosis and majority of women, 59.2%. A dose-dependent effect was demonstrated. Greater the dose, greater the effect. Taking one defined daily dose of statins on average was associated with 0.63 more MMSE points after 3 years compared to non-statin users. So there was an improvement in the cognitive scores compared to those who are not using it. Simvastatin users showed 1.01 more MMSE. So pretty good after 3 years compared to atorvastatin. Younger, 79.5 years at index date, simvastatin users had zero point 0.8 more MMSE point compared to younger atorvastatin users after 3 years. Simvastatin users had 1.03 more MMSE points compared to rosuvastatin after 3 years. No difference regarding statin lipophilicity was observed. That means lipophilic, hydrophilic didn't matter. The results of sensitivity analysis restricted to incident users were not consistent. Conclusion: some patients with Alzheimer's disease or mixed dementia with indication for lipid lowering medication may benefit cognitively from statin treatment. So here the statin are addressed for cognitive benefit, not for lipid lowering, although they needed lipid lowering as well, and that's why they were using it. However, further research is needed. So this is another study, interesting study. This study now goes into the mechanisms, and I have already discussed the mechanism, so just very quickly I'm going to show it to you. So this is the statins as anti-inflammatory agents in atherogenesis, molecular mechanism, and lessons from the recent clinical trials. So they have discussed mostly what we know already from our discussion. What I want to read is just this one paragraph. So here we have recently demonstrated that co-incubation of human vessels, so they put human vessel with statins and mevalonate. So remember, I actually kind of alluded to this study before. So they are talking about taking a blood vessel, human blood vessel, or its cells, put statin with it. So you would expect that this pathway will now be blocked. But imagine we do not know that this pathway is blocked or not. Then they also added mevalonate in here from outside. So the statins were blocking it, but they were giving it from outside, and the blood vessel had the same inflammatory reaction as if statins were never present. This proved to them that the statins work through this pathway. So we have recently demonstrated that co-incubation of human vessels with statins and mevalonate reverse the beneficial effects of statin on vascular redox state, reactive oxygen species state, inflamed state. Such findings highlight the importance of the mevalonate pathway in mediating the pleiotropic effect of statins in humans. Pleiotropic, multiple types of effects of this drug. So then they say L-mevalonate, levomevalonate, is a precursor in the formation of important isoprenoids. So these are all called together isoprenoids. Even CoQ10 has an isoprenoid tail, which is this FPP, this guy. So L-mevalonate is a precursor in the formation of important isoprenoid intermediates such as farnesyl pyrophosphate or FPP and garnyl pyrophosphate or GGPP. These molecules are responsible for post-translational modification of proteins by covalent addition of farnesyl or garnyl groups to cysteine residue. And I discussed that over here, that this is a protein. Post-translational modification means that a protein is made, it has been translated, then we are modifying it. So it was not born that way. It was born without this modification. Then a bunch of enzymes came in and created another modification on top of it. Like people get ear piercing or something, or some other things on their body. So that is a modification afterwards. So that's what they're saying, that these two will do prenylation by doing a modification, by becoming attached to this protein. It was not born this way, but now it has this little hook with it. This process, so these molecules are responsible for post-translation modification of proteins by covalent addition of farnesyl or GGPP to cysteine residue. This process is named prenylation and affects numerous signal transduction molecules. Why signal transduction molecules? Because their job is to attach to the cell membrane and then listen to the signals from outside, and they're listening from inside, and then they respond. So they need to be stuck to the cell membrane, so they need prenylation. In vascular and myocardial signaling pathways, an important group of such intracellular signaling pathway modulated by statins involved. So these are the ones that get modulated by statin. There may be many other proteins that are stuck to the cell membrane, but these are the ones that statins affect. Small group triphosphate binding proteins such as Rho, RAC, and RAS. These small GTP protein help regulate pro-atherogenic, pro-inflammatory pathways. So what do? Rho protein are involved in the expression of pro-inflammatory cytokines, interleukin 6, tumor necrosis factor alpha, and CRP, as well as in the formation and maintenance of actin cytoskeleton for the movement of the cells. The RAS protein regulates cell proliferation, increase in number, and hypertrophy, thickness. So this increase in number and thickness is good in some cases. For example, immune systems should increase in number when we need them. And the hypertrophy of our muscles should happen when we are exercising them. But what about the heart getting hypertrophied? That is bad. Or extra immune cells getting produced, which would go and attack the body. That is bad. And then RAC transduction signaling modulates ROS generation. So do you remember how RAC will go and become part of NADPH oxidase, which would then make reactive oxygen species. So if you affect RAC, then ROS generation will reduce. Then here is a diagram, statins reduce nuclear factor kappa B pathway. I discussed that earlier. Then here is another, statins disrupt macrophage RAC1 regulation. So this is macrophage. Here is RAC1, which then becomes activated, produces interleukin 1 beta, and then all the other inflammatory outcomes. And statins block this. So here is Rho, here is RAC. Then anti-inflammatory effects of statins, clinical evidence and basic mechanism. I have already discussed the mechanism, and this was a paper to be bought. The diagram in the paper is here. So NADPH oxidase C, it is in the cell membrane. And here is RAC1. It will go become. So if you look at NADPH oxidase, it is not one enzyme, one protein. It is actually a complex of many proteins that will come together to act like a car, the reactive oxygen species producing factory. And one part of that is RAC. That needs to be here as well. But statin will block GGPP, which would then block RAC1, and that would cause NADPH oxidase not to work as nicely and efficiently, or not to work at all. Then anti-inflammatory effects of statins, clinical evidence and basic mechanism. So we've seen that. This is another one, also interesting. The basic idea here is also the same, that here RAC seems to be interesting and statins seem to be interesting there. And then finally, the statins and cognitive impairment. Our findings suggest that statins are associated with lower but short-term cognitive performance or cognitive decline, short-term, by lowering low-density lipoproteins and raising blood glucose. I have already explained this mechanism. And better performance by lowering C-reactive protein concentrations. So this is the discussion. I'm going to stop recording and we'll do some chit chat as well.